Welcome to AETCM, the emergency medicine channel.
Yes.
A 78-year-old female presented to the ER with complaints of fever since 5 days duration associated with pain and swelling of the right leg since 5 days. On our initial 10-second assessment, the patient was conscious, oriented and obeying commands. Coming to airway was patent, no secretions. Coming to breathing, air entry bilaterally equal with a respiratory rate of 18 per minute with a saturation of 97% in room air. Coming to circulation, BP of 160/80 millimeters of mercury, pulse rate of 92 beats per minute. All peripheral pulses were equally palpable. At this point of time, we have used a handheld Doppler to look at the peripheral pulses of the right lower limb. Coming to disability, GCS of 15/15, pupil bilaterally equally reacting to light. Coming to exposure, temperature of 100.2 degree Fahrenheit with a GRBS of 240 milligram per deciliter. The patient gives a pain score of 3/10. At this point of time, we have inserted one large bore IV cannula and injection PCM 1 gram IV stat was given. Coming to adjuncts of primary survey, we have taken a VBG showing a pH of 7.405, PCO2 of 43, bicarb of 23, lactate of 1.9, creatinine of 1.01.
What is the difference between that venous blood glucose and arterial blood glucose here in this patient?
Actually, the pH will be
pH, I am asking sugar.
10 to 15 variation.
10 to 15.
Capillary glucose and
What is the difference in capillary glucose and venous glucose levels? Acceptable levels. What is acceptable levels? Is there a chance of error?
yes, error
What are the chances of errors in when you are taking a arterial capillary blood glucose? Should know all these things.
errors.
Error. What are the chances of errors when you are taking a capillary glucose? 10 to 15% error is possible. Why error?
Because of the sterilium and sterilium content would be there, other thing would be the
If you don't wipe properly, that will add to the blood and reduce the sugar. Then if you press more, what will happen?
lysis.
Then what happens?
Cells glucose will
Release. So it will be high. So there is a chance of error always when you are taking the capillary glucose. In your venous sample, mostly it is normal. It may be comparative with your lab glucose. Okay.
We have done a CBC CRP point of care showing a total count of 12,000 and a CRP of 72, platelet of 240,000. We have also done a point of care ultrasound to look for any features of DVT and also IVC and the cardiac status of the patient.
Mm-hmm.
We have also advised for an X-ray since there was pain and edema of the right lung.
Before going to the costly investigation, how do you assess a patient who is having swelling in the legs and which is you are suspecting there is a possibility of infection, cellulitis? How do you assess it? What are the first tell me the possibilities and how do you rule out each one?
So the differential diagnosis of a unilateral lymphedema can be most common as cellulitis.
Okay.
Can be DVT, lymphedema, any trauma, inflammatory arthritis, any rupture
arthritis?
of the gout.
Okay.
And any rupture of the muscles.
Okay.
These are the most common DDs.
Okay.
When it comes to cellulitis, there can be
Tendinitis.
tendinitis.
Tendinitis is another condition where the patients, like one of the common scenarios, patients are treated with which drug?
tendinitis.
Tendinitis is common in which common drugs what we use in our clinical practice? Fluoroquinones. Those who are taking fluoroquinones 1 or 2 weeks, they can develop tendinitis. So they also can present with lower limb inflammatory signs. Okay.
And based on the history, the patient gives a history of fever, any history of any trauma, following which developing redness, pain, edema, point towards an infectious etiology, point towards a cellulitis.
Okay.
In the case of DVT, the patient complains of any history of recent surgeries, immobilization, any OCP intake, any carcinomas, any autoimmune conditions like that on history, and acute onset swelling and calf muscle tenderness.
Will you elicit that?
No, sir. This will dislodge the clot, sir, actually.
So once you are thinking that it is DVT, should never examine that limb. Just keep the limb like without any disturbances. Then you can do your Doppler study. Okay.
In case of lymphedema, we will ask in history from endemic areas. We will palpate the lymph nodes.
Endemic area of
filariasis.
Okay.
And we will look for any lymph nodes, and there is no other features, no features of any local rise of temperature, no fever, no source of any infective pathologies.
Okay.
And other cases, we will look for any history of any trauma.
Okay.
Like that. So.
Okay.
Coming to sample history, a 78-year-old female, known case of type 2 diabetes, bronchial asthma, hypertension, dyslipidemia, presented to the ER with complaints of fever since 5 days duration and associated with right lower limb pain and edema of 4 days duration. The patient gives a alleged history of trauma where she hit the right leg over the chair, following which she developed a lacerated wound over the medial aspect of the right leg 3 cm above the medial malleolus, and next day onwards she started to notice redness, edema, which was gradual and progressive. Later she developed fever with chills, which was intermittent and decreased on medication. No history of any immobilization, surgery, breathlessness, palpitation or syncope. No history of any loss of sensations. No history of any blackish discoloration of the right leg. No history of any unknown bite, joint pain. No history of any contact with any marine environment. No history of any decreased urine output, altered behavior.
Why marine environment is very important?
So the organisms,
What organism?
Vibrio species, Vibrio, Parahemolytis, Polynefacius.
Okay. Okay.
Coming to past history, no history of any similar episodes in the past. The patient is a known case of diabetes on OHAs, hypertension on telmisartan, and bronchial asthma on inhalers. Medication history on metformin 1 gram BD, hypertension, telmisartan 40 mg OD. Last meal was taken at 6 am, sir. Coming to examination, no pallor, no stress, cyanosis, clubbing, generalized lymphadenopathy or peel edema. Coming to systemic examination, all the systemic examination was within normal limits. Coming to local examination, redness was present over the medial aspect of the right leg, extending 3 cm above the medial malleolus and 8 cm below the tibial tuberosity. A local rise of temperature was present. Peripheral pulses were equally palpable on both the sides. No crepitus, no palpable lymph nodes. Capillary refilling time was normal. No restriction of any movements. Weight bearing was present. Pinprick test was done, which showed bleeding. So our provisional diagnosis was cellulitis.
Okay. What is this capillary refill time?
Press the tips of the finger or the toes, and then see for when released, see for the return of the reddish coloration.
That indicates what?
Blood flow to the capillaries.
That
Perfusion of this.
So it shows a good perfusion in the body. Okay.
So at this point of
That
time,
possibly rules out septic shock.
initially we have managed the airway breathing circulation only in the exposure part. The temperature was 100.2 degree Fahrenheit with a pain score of 3/10. We have given injection PCM 1 gram IV stats. Then we come to diagnosing our condition. We did a USG, a point of care
What is the
ultrasound.
importance of pain score in ER? He has told pain score, but he didn't follow up. What is the importance?
In here we will follow the WHO pain ladder, sir, where it will classify into mild, moderate and severe 1 to 4, 4 to 6 and 6 to 9. In mild cases we will give NSAIDs or in paracetamol, and in moderate cases we will give mild opioids like tramadol can be given. In severe pain we can give severe opioids like morphine even can be given.
Okay. Did he follow up the patient after
Yes,
that?
sir. Yes, sir.
After your paracetamol, he improved pain
Yes, sir. We
score?
reassessed the patient. The pain score came down to 1/10. Sir.
Okay, so that is very important. Pain is the 5th vital sign in hospital nowadays. Okay, pulse, BP, temperature. And next one is pulse, BP, temperature. One more is respiratory rate, then pain. Okay.
Then we have done a USG Doppler and we have ruled out DVT, sir. Then
How do you rule out DVT by Doppler?
sir, basically with USG in DVT, where we can see non-compressibility of the venous veins and increased flow in the superficial veins and absence of phasic flow, sir. Whereas in the case of cellulitis, we can see the cobblestone appearance can be seen. And in the case of necrotizing fasciitis, we can see irregularity in the fascia and hyperechoic foci with the reverberating artifacts can also be seen in necrotizing fasciitis. Then we have given the local examination we have done to differentiate between cellulitis and necrotizing fasciitis, sir.
You explain me how will you do local examination in the case like this?
So one is based on the history, the progression of the disease. Then in local examination, we have in inspection we have to look for a necrosis of the tissues.
I'm not asking that. I know that you can examine. I'm asking the steps.
First, we have to sanitize ourselves.
How many times you have sanitized your hand before examining the patient? Is it important or not?
Yes.
Why it is important? Before touching the patient and after touching the patient, you have to wash your hands or you have to clean with your ceruleum which is available. So why it is important? In this case especially it is very, very important. Why it is important?
One is we are not introducing the infection and
we no need to introduce it. It's already infected. Why we are worried about
the cultures can...
Why we are worried? As a ER physician, it is your responsibility to clean your hands. Why?
We will introduce
We
infection
are not
others.
going to introduce anything this patient because he is already infected.
To others, we will
So
introduce.
if you touch and if you don't wash after that, the bacteria which is present in that wound can spread to others. Which bacteria we are worried about?
MRS.
MRS. So you have to wash your hands thoroughly before examining this type of cases. Any case you have to do it like that, but this case are especially there. They can have MRSA. Okay.
Then, sir, we have looked at the inspection findings and we have done the pinprick examination, show bleeding. So we have ruled out necrotizing fasciitis. We have also kept the limb elevation and adequate dressings was given and cultures from the site was also taken, sir. Then we come to the choice of antibiotics, sir. This patient, this is the first
What dressings you can give for this patient? Magnesium sulfate. Okay. What is the action of magnesium sulfate?
Reduces the edema.
It reduces the edema. Okay. So if you dress it, you keep for a long time. What happens?
Dry.
It will become dry after some time. So you have to repeat the dressing. If you want to change, after 1 or 2 hours you have to change it. Otherwise it will become hard.
Then we come to the antibiotic of choice. This patient...
saline dressing? What about saline dressing?
Can also be given, sir. Can also be given.
Salt water.
Yes.
It will not allow the bacteria to grow. So that also many surgeons try it. Okay.
Then we come to antibiotics, sir. The patient is the first episode of cellulitis with no ulcers, no recurrent, no.
What is the difference between first episode of cellulitis and repeated episodes of cellulitis?
So the first episode of cellulitis, we are suspecting a gram-positive organism, mostly streptococcus.
Gram-positive organism like streptococcus or staphylococcus, especially MSSA. Okay. Second episode, third episode, fourth episode, repeated admission. What is the change?
In recurrent episodes, we are suspecting a gram-negative plus MRSA.
Okay. You can have anaerobic organism. You can have MRSA. You can have gram-negative organism. So the organism, flora of organism will be completely different in repeated episodes. That is the difference. Okay.
So in this patient, this is the first episode of cellulitis and the patient is coming from the community itself. Okay. So we are suspecting a gram-positive organism.
MSSA is the most common organism. Okay.
So we have started the patient on injection flucloxacillin 1 gram Q6X.
Okay. What are the antibiotics which are sensitive to MSSA? Sensitive.
One is penicillin group of antibiotics.
In that penicillin group itself, which is the most important?
Cloxacillin.
Cloxacillin or flucloxacillin. Whereas amoxicillin, ampicillin, they may be sensitive, but sometimes it will not work. Okay. So it is better to go for flucloxacillin or cloxacillin. Cloxacillin is not available nowadays. Only flucloxacillin is available. Or you have to go for MRSA treatment. So that we normally in an institute we don't practice like that. We go for MSSA treatment only.
And we have started the patient on injection flofloxacin, sir.
Okay, what is the dose of flucloxacin?
1 gram IV Q6H was given, sir. Then we come to the
Should we give test dose for this? Yes or no?
Yes.
Confidently, you have to-
yes, medical test.
all penicillin groups we have to give test dose. This third generation cephalosporin,
Yes.
can penicillin allergy can spread to cephalosporins? Suppose somebody is having penicillin allergy, can they have cephalosporin allergy? All these things are entrance
Beta
questions.
lactams,
That's why I'm
they-
asking.
Beta
You
lactams.
recently cleared entrance NEET. How many percentage of patients can have cross allergy between penicillin to third generation cephalosporin? 30% can have cross allergy. So if somebody is having a penicillin allergy, they may have allergy to ceftriaxone. So in that case also, anyway we have to give test dose. Which are the antibiotics we normally don't give test dose? It is not required.
Azithromycin.
Citromycin it is not required. Quinolones are not required. Doxycycline is not required. Okay.
Then the labs came, sir. The labs came HbA1c 8.1.
Okay.
So we will go ahead with the adequate glycemic control of the patient, sir. Because it can be the uncontrolled sugar that has triggered the cellulitis, sir.
Okay.
Then we also started on DVT prophylaxis.
Tell me something about HbA1c.
It is the measurement of 3 months of the sugar in the body, like the
Glycemic control in the last
body.
3 months.
3 months.
Last month?
90% would be attributed to the last month.
50%.
50% to the last.
50% of the sugar values are contributed by last month. 50% is from last 2 months, previous 2 months. So it is high. 8.1 is high. So what do you do now? So we have started flucloxacin. We have addressed the patient with magnesium sulfate. Then
And limb elevation were given.
limb elevation is given.
And
Then
DVT prophylaxis we have started.
what DVT prophylaxis you have started?
We have started on injection heparin, sir.
Heparin. Okay. Then
And then glycemic control, sir.
how do you control the blood sugar?
This point of time, sir, we again reassess the GRBS, sir. The GRBS came out to be around 400, sir.
400.
400. So we have started on insulin infusion, sir, actually. Followed by 4, we have started on 4 units
Is it
per hour.
really required to give insulin infusion this type of patients? You tell me the exact indication. We have started, that is a different issue.
Hyperglycemia and sepsis to control to range between 1-8.
Tell me the indications for
HbA1c more than 10, we are
tell me the
suspecting.
indications for insulin infusion.
HbA1c more than 10, we are suspecting decay.
We are not suspecting decay.
High sugar.
High sugars not an indication for insulin infusion.
Patient in septic shock.
Septic shock, okay. Then severe sepsis, septic shock. That's okay. Septic shock is one indication. Then why in decay we use insulin infusion? It is not because sugars are very high. It is something else is there. If you understand the reason, then you will never try to start insulin infusion unnecessarily. What is the indication for insulin infusion? Septic shock, he has told. That is a correct answer. One more answer you have to tell. That is there in diabetic ketoacidosis. Suppose somebody's sugar is 600, you no need to start insulin infusion. You can very well give subcutaneous insulin. So there is a reason for that.
Tight control about this. Like
There is not tight control. There is no difference in action subcutaneous to IV. What is that difference? It is the dehydration. Okay. When the patient is dehydrated or like you told shock, insulin will not be circulated properly where you are injecting under the skin. Okay. That's why you are giving direct IV. If the patient is not dehydrated, should we use insulin infusion? It is not required. It's a very costly procedure in most of the hospitals. So you just give subcutaneous, that is more than enough. Only advantage of insulin infusion means whenever you want to stop, you can stop it. Suppose patient go to hypoglycemia, immediately you can stop it and patient will recover. But if you are giving a high dose as a subcutaneous insulin, that will remain there and continuously it can create problem. Okay. So if not required, better not to give insulin infusion. That is not having any added advantages unless you have dehydration or like you told shock. there is no point in giving insulin infusion. There is a very costly treatment in many hospitals. Okay.
Then after 3 days the culture report came, sir. It was medicinal sensitive Staphylococcus aureus, which was sensitive to
MSS.
MSS.
Okay.
Sensitive fluclococcus, and we continued the fluclococcus and CRP total counts everything downtrending.
Okay. So if you are using correct drug in this condition, is the ideal situation to use flucloxacin. Otherwise, flucloxacin is not a very useful drug in many conditions. We have better options. This is exactly this condition we have to use flucloxacin, and patient will respond very fast. Suppose it is MRSA, what is your treatment? MRSA.
Vancomycin can be given.
Vancomycin can be given. Linezolid can be given. What are the things you have to be careful when you are giving vancomycin, linezolid, all these things?
Platelets has to be monitored.
Platelets should be normal to give linezolid. Vancomycin?
Redman syndrome.
Redman syndrome is different. What is Redman syndrome? What is Redman syndrome? He is reading now. He cannot read now. What is Redman syndrome? Eh? You are told. You have to answer. This is a problem in exams. You tell unnecessary things. Somebody may ask you questions.
Sudden flushing histamine release.
I am asking what is Redman syndrome. You are telling the mechanism behind it, Redman syndrome.
After the administration of vancomycin,
In all patients should
no
If
patients.
you are giving faster rate of vancomycin, then patient develops, like he told, there will be sudden release of histamines, and he develops generalized rashes all over the body. So you have to reduce the speed, then you can give. So that is Redman syndrome. Vancomycin is known for that. So vancomycin can produce Redman syndrome if you give it in a faster rate. What is the most, any other things you have to monitor?
LFTs.
Vancomycin, LFT can produce, but any other creatinine? Creatinine is the most important thing we have to monitor during the therapy. Okay. So, third day. So after 3 days, you can check the creatinine. If it is elevating, then we have to be very careful. Okay. Either you have to reduce the dose or change to some other drug. Okay. Okay. Then, what is the magnesium level of this patient?
Magnesium was normal, sir. 2.2.
What is the importance of magnesium in diabetic control?
Insulin action, magnesium will be.
Insulin action will be?
For action of insulin, magnesium will be there because of ROK channel to activate magnesium.
So to make the insulin enter into the cell, you require good magnesium levels. Suppose your magnesium is 1. Now our lab value is 1.8 to 2.4. 1.7. Can you assess the total magnesium deficiency in your body?
No, sir.
Why it is like that? Why it is like that? We cannot assess. Here we can only tell it is low. How low it is, we cannot assess. Why it is like that?
It's not the clear picture. It's stored in the bones and.
You tell me like a postgraduate student. Don't tell it will not give a clear picture. I know that it is not a clear picture. But what is a clear picture? Only 1% of your magnesium is in your body is reflected in your blood test. Rest 99% is somewhere else. So you don't get a clear picture like he told. You don't get a clear picture at all. We can know that magnesium is low. Magnesium is required for so many metabolic activities in our body, including insulin action, bronchodilation, diaphragmatic action, brain function, muscle action, cardiac rhythm action. Everywhere it is required. But we cannot assess how much low it is. Okay, so we have to be very careful. Any other problem he had other than this?
No, sir.
Now, how do you prevent reinfection in this patient? Suppose a patient like repeated cellulitis, like what is that condition? Elephantiasis. What is elephantiasis? Elephantiasis is what? Filariasis. Okay. How do you prevent repeated infections?
Pendits can.
What is pendits?
Pencil.
Oral penicillin. Oral penicillin can be given as a prophylactic for a long time in this type of patients. That gives benefit to the patient. Okay. There are some other treatment like massaging of limb. All these things can reduce the inflammation in that area because skin will be very dry in that. Okay. So that also can be tried. But here it is only because of diabetes he is developing all this problem. Okay. Diabetic autonomic neuropathy. Okay. Is the touch sensations are normal in this patient?
Yes, no,
It's normal.
no decreased sweating, no dryness, nothing.
Okay. Okay. Anything else you want to add? You want to add something about cellulitis? Nothing. Okay. Thank you.